Hello, everyone. For those who weren't able to join us last time, my name is Nita Kessler, and as Operations Manager for Capstone Performance Systems, I'm very glad to welcome each of you to our ICD-10 webinar series. Today is the third presentation in this series, and we are excited to have over 170 registered for today's session. Please remember that you will need to register for each session if you haven't already. The webinars will be recorded and available for download from our website, www.capstoneperformancesystems.com, by navigating to the ICD-10 Support tab on the top menu. The PDF handout of today's slides is available on the Start Meeting Event webpage, where you can also find the handouts for sessions 1 and 2. Capstone is pleased to sponsor this series for our PACE clients, friends, and the larger PACE community. We have been helping PACE organizations improve documentation, compliance, and revenues for over 10 years, and have had the pleasure of working in over 2/3 of the programs in the U.S. We've learned a lot over these years and hope to share some of that with you over these next few weeks. Again, in addition to this series, we also recommend that programs and providers take advantage of the many available resources in your local health systems and through online programs to learn about ICD-10 and documentation improvement. Capstone also offers additional training and support to our clients, so feel free to contact us if you have any questions about our services. Our goal in these webinars is not to make coders out of primary care providers or others. We understand that many electronic health records require that a PCP select a diagnosis code as part of the encounter documentation. Unfortunately, we have seen this leads to many coding errors. We do think that by learning some of the material in this series, providers will become more adept at ICD-10 coding. But more importantly, we want providers to understand how coders think, to recognize the guidelines that inform their thinking, and to become cognizant of the mental shifts that are necessary to best meet the documentation requirements of ICD-10. Also, during this presentation, we will take a few opportunities to pause and check to see if anyone has any questions. At that time, if you have a question, please press *6 on your phone and you will be entered into the queue. Please hold your questions until those times. I now want to introduce Angie Ladd, RN and Certified Coder, who is head of our coding department here at Capstone.
Good afternoon, everyone. I would like to welcome you all to Webinar 3, Documenting CHF, Hypertension, CAD, and Angina. With me today is our guest presenter, Pat Sherman. Pat is a registered Health Information Administrator and Professor in Health Information Technology. Before we get started today, I would like to say that it is our goal for these webinars to be both educational and beneficial to those listening. The content is geared towards helping you understand the changes in ICD-10 that will affect your documentation and coding. We strive to give you pertinent information that will best accomplish this task. We will conduct things a little differently for the question and answer session today. During this webinar, we will take questions at various intervals as well as at the end. At the end of each condition, I will pause and ask if there are any questions. At that time, you can press *6 and be entered into the queue to answer questions. To ask questions, rather. Pat, would you like to begin today's session?
I certainly will. Thank you. And again, welcome and hello to all listeners. We'd like to give a brief overview for Seminar 2. We're also going to review Chapter 9, Disorders of the Circulatory System, as well as reviewing documentation and coding for CHF, heart failure, hypertension, CAD, and angina. We're going to look at hypertensive diseases, the I series, I-10 through I-15-9, I-20 through I-25.9, ischemic heart diseases, and I-26 through I-28.9, pulmonary heart disease and diseases of the pulmonary and circulation. Now, let's review some of the elements from Chapter 4, endocrine, nutritional, and metabolic diseases. There are 5 categories for diabetes mellitus compared to 2 categories in ICD-10. The most salient feature had to do with the expansion to reflect the manifestations and complications of diabetes by using 4th or 5th characters rather than using an additional code. So combination codes are important, and remember to link the diabetes to the complication. In ICD-10, it does not classify diabetes as out of control, poorly controlled, or inadequately controlled. There are codes available to report hypo and hyperglycemia. Now, vascular disease overview in ICD-10, arteriosclerotic vascular disease, or atherosclerosis of the extremities. The categories were expanded to increase specificity with the use of laterality, the use of ulcer site, and the use of severity notation for bypass graft. There are over 100 codes for vascular disease in ICD-10 compared to 10 codes in ICD-9. ICD-10 for chronic kidney disease and neuropathy overview. The salient features are for chronic kidney disease in 10, very similar to how we coded and documented in ICD-9. There are 7 codes for chronic kidney disease, stages 1 through end-stage renal disease, and unspecified. We want to always include the code for dialysis status if it's applicable, which is Z99.2. And we want to be sure to document neuropathy as mono or poly, keeping in mind to document the laterality, right, left, or both sides. Now, if there are any questions about any of the overview, we can pause now and take some. I'm going to turn it over to Angie at this point, and I thank you.
Hello again, everyone. As Nita said in the beginning, the slides and recording of this and previous webinars, and obviously future webinars, will be available on our website at www.capstoneperformancesystems.com and navigate to the ICD-10 preparation tab. Okay, so today we're going to talk about heart failure, hypertension, CAD, and angina. And as I said, my main goal is to help you with what you're going to need to know for better documentation. My goal is not to tell you this is the code you need to choose, but because the coders are going to know that. But you need to know what is going to be required of you in terms of documentation. So let's start with hypertension and hypertensive diseases. So in ICD-10, hypertension is limited to the number of ICD-10 codes. So there are 9 codes for primary hypertension, and there are 5 codes for secondary hypertension, compared to ICD-9, where there were 27 codes. So you had your 401, your 402, 403, and 404 series. Now we are limited to the choices that we have in codes. Also in ICD-10, there is no longer, this is partly why, there is no longer a distinction between malignant and benign hypertension. They are now lumped into the codes that are under the title of essential hypertension, and you're going to see that here in the next slide. So I-10 is hypertension, essential, or primary hypertension. This does include high blood pressure. The important thing I want you to know about this category is that it begins with a capital letter I. So do not confuse it with the number 1, which I know this is going to happen. I think ICD-10 should have not used the capital letter I, but this is out of my control, so it is as it is. So ICD-10 coding for hypertension compared to ICD-9. So as you will see the two comparisons there. In ICD-9 for hypertension, you had malignant, benign, and unspecified. In ICD-10, so you had 3 codes in ICD-9. ICD-10, you have 1. I-10, that's it. It encompasses arterial, malignant, benign, essential, primary, and systemic. Those are all included in that I-10 category. So coding for hypertension and or hypertensive diseases. I-10, again, is hypertension. I-11 are your hypertensive heart diseases with or without heart failure, and you must state the causal relationship. We will get to that in a few slides. I will expand on that here shortly. I-12 is hypertensive chronic kidney disease only, which means it does not include the heart failure. It's only hypertensive kidney disease. The causal relationship is assumed by guidelines. This did not change from ICD-9. I'm not exactly sure why it is such, but if you have hypertension and CKD, by guidelines, it is an assumed relationship. It does not need to be stated. You also, in this category, need an additional code for the stage of chronic kidney disease. I-13 is hypertensive heart and chronic kidney disease. Again, this one has to be designated with or without heart failure. You need an additional code for the stage of CKD, and you need an additional code for the type of heart failure. Now, I know that I-12 and I-13 seem like they're the same thing, but they're not, and we will see that here in the next few slides. And then the last category is I-15, which is secondary hypertension. You must also code the underlying condition. Coding hypertension in ICD-10. In 10, there is no distinctive code for controlled or uncontrolled hypertension. You just need to assign the appropriate code from the I-10 through I-15 categories, whatever it may be. Also, as in ICD-9, there is a code for elevated blood pressure without the diagnosis of hypertension. I think it was in the 700 series in ICD-9. And in ICD-10, it is R03.0. So if you have somebody that comes into the clinic and has an elevated blood pressure, but formally or without formal diagnosis of hypertension, this is the code that you would use, R03.0. And on the opposite end, there is also a code for a nonspecific low blood pressure reading, which is R03.1, which is not to be confused with a hypotension code, which is in another category, I-95. So nonspecific low blood pressure, R03.1, hypotension is I-95. One more thing I want to point out about hypertension is that in ICD-10, the hypertension table that you may have all been used to no longer exists in the code book. So at this time, are there any questions regarding hypertension, the hypertension that we just covered? Okay, moving on. If you think of something, you can ask it at the end, but I wanted to give you time per condition to ask a question. So we're going to talk about hypertensive heart disease, and this is where the difference is, these next few slides. So hypertensive heart disease, examples of heart problems associated with hypertension are cardiomegaly, or LVH, left ventricular hypertrophy, coronary artery disease and angina, and chronic heart failure. These are the heart diseases that are to be meant when we are speaking of hypertensive heart disease. The guidelines from ICD-9 to ICD-10 did not change for documenting hypertensive diseases, which means that if the heart condition is, which I just mentioned, the cardiomegaly, CAD, so on and so forth, is caused by the hypertension, then it should be documented as hypertensive heart disease with, and then whatever the heart condition is. So hypertensive heart disease with heart failure, or so on and so forth. So coding for the hypertensive heart diseases. So the heart conditions that are classified to I-50 or I-51.4 to I-51.9 are, so which those conditions are myocarditis, myocardial degeneration, cardiomegaly, we talked about that, LVH and CHF, we talked about that. So those are the heart conditions. So the point is to assign a code from category I-11, which is the hypertensive heart disease, only when a causal relationship is either stated as due to hypertension or implied, such as hypertensive. You also need an additional code from category I-50, the heart failure category, to identify the type of heart failure in those patients with heart failure. The same heart conditions with hypertension, but those that don't state a causal relationship are coded separately. So, for example, there's no single ICD-10 code for quote-unquote hypertension with heart failure. The correct documentation would be hypertensive heart disease with heart failure or heart failure due to hypertension. This is the difference when you are talking about hypertensive heart diseases and hypertension with a disease. So, as I said, correct documentation, hypertensive heart disease with heart failure. You're saying at this point that the heart failure is the heart disease that has been caused by the hypertension. So documenting hypertension with CHF or heart failure does not indicate a causal relationship and would not be coded as a separate diagnosis, or it would invite a query from the coder. Now, I know that's confusing, and what I'm going to say next may not make any sense to you. It doesn't really matter if you do it that way. And the reason why I say that is because, not to discourage you from documenting correctly, because I think that you should document correctly. But the point is, if you say hypertension with heart failure, it's going to be coded, it's going to be given two codes, code for hypertension and the code for heart failure. It maps to HCC 85. If you say hypertensive heart disease with heart failure, it's going to get the ICD-10 code I13.0, and it's still going to get HCC 85. So as we usually talk about in the training when we come to visit you, if you're as long as you're documenting your hypertension with your CHF or with your kidney disease or what have you, you're going to get the HCCs that you would if you would have said hypertensive heart with kidney disease and heart failure. So that's more for coding and coding guidelines than it is anything else. But I did want to mention it because it's proper coding. Okay, hypertensive heart disease with CKD. You have hypertension with CKD and hypertensive heart disease with CKD. Hypertension with CKD or hypertension CKD is I-12.0 through I-12.9. Same guidelines follow for ICD-10 as they did ICD-9, which is meaning that the relationship, as I said earlier, between the hypertension and the CKD is assumed. Hypertensive heart and CKD with or without heart failure is I-13.0 and I-13.2. Again, an additional code is needed for stage of CKD, which is the N category, 18.1 to 18.6, and an additional code for the type of heart failure, I-51.I-50.9. Okay. The biggest change from ICD-9 to ICD-10 is the word congestive. It is now included in the diagnosis for heart failure. So, for example, in ICD-9, if you said systolic congestive heart failure, you would have needed two codes, 428.0 and 428.20. In ICD-10, the word congestive is included in the description, and the example there is exactly how it looks. Systolic, congestive in parentheses, heart failure, and you need one code, I-50.22. That's not a huge issue for the providers as much as it is the coders. It's just now it just makes it more simple. In ICD-10, it's basically the same, and I'm going to show you a side-by-side comparison here in the next slide. But so we have the same categories as in ICD-9. We have left ventricular failure, we have systolic and diastolic heart failure, combined systolic and diastolic heart failure, and unspecified heart failure. We also have the same fifth-digit requirement. 0 is unspecified. 1 is for acute, so acute systolic heart failure. 2 is for chronic systolic heart failure, and 3 is acute on chronic, which would be acute on chronic systolic heart failure. So the comparison is here, and you see the only thing different is here where in ICD-9 there was a code for congestive, and now there is not. But if you look, they're almost identical. So the example I have, the additional codes for other causes of heart failure are listed there. You can have rheumatic, heart transplant failure, post-procedural heart failure, so on and so forth. I have this in here so just so you would note that it's not all in the I-50 category. If the heart failure is caused by another condition, then it's going to be in a different category. Okay, so example. Patient is seen in the clinic for complaints of headache, increasing dyspnea on exertion, and increased edema bilateral lower extremity. They ate popcorn and pizza over the weekend. So, objective, the blood pressure is 180/100, can't buy basilar rails, plus suiciding edema bilateral lower extremity. The assessment is hypertensive heart disease with acute on chronic systolic heart failure. The plan is for furosemide, 80 milligrams IM now, times 1 now, increase lisinopril to 20 milligrams POBID, recheck in clinic after lunch, review guidelines. So the codes for this example would be I-11.0, hypertensive heart disease with heart failure, I-50.23, acute on chronic systolic congestive heart failure, both match at HCC 85, which is heart failure. Okay, any questions on congestive heart failure or heart failure coding or documentation? Okay, moving on. We are going to talk about ischemic heart disease. So, chronic ischemic heart disease, the category I-25. This is atherosclerotic heart disease, which includes coronary artery disease, arteriosclerotic cardiovascular disease, coronary artery atherosclerosis, so on and so forth. What's new in ICD-10 is the combination codes, which are I-25.11, either 0, 111, 118, or 119, for the atherosclerotic CAD with angina pectoris. So the combination code means that there is no additional code needed for angina. In this particular category of codes, a causal relationship is assumed if the patient has both atherosclerosis and angina. The only reason it wouldn't be assumed is if the documentation stated otherwise. So, in other words, if the documentation stated that the angina was a cause of something else, then it would not be assumed. But your combination codes for this category are going to include angina pectoris. You have to state with or without. So there are codes for with and there are codes for without, which we should see here when I show you. Also, for the I-25, the CAD category, we must designate in the documentation whether it is CAD of the native artery, CAD of the bypass graft, and or CAD of a transplanted heart, whether it is native or bypass graft. Now, this did not change from ICD-9. However, very rarely is it documented where the artery disease is. I can almost say 100% that I've never seen it, unless there was no documentation that they had any kind of sense or anything like that. Most of the time, there's no documentation. But let's practice putting this in our documentation. We should say CAD of the native artery or CAD of the bypass graft. You don't have to know which bypass graft, if they have multiple, because there is a bypass graft unspecified, but it should be stated. You can use an additional code to identify if they have any chronic total occlusion of the coronary artery, which is I-2582. Exposure to environmental tobacco smoke, here's one of the categories that has this requirement. Exposure to environmental tobacco smoke, if the provider feels that it is related or is related to this condition. So if it caused this condition, then they can you can put that documentation in. Any history of tobacco use, any tobacco dependence, or any ongoing tobacco use. So the differences from 9 to 10 are, in ICD-9, coronary atherosclerosis was the title, and there was 8 codes specific to CAD. In ICD-10, it changed to atherosclerotic heart disease, which all that changed were the words, basically, and there are 36 codes specific to CAD. So specificity and combination codes in terms of the angina are the main differences between 9 and 10. Ischemic cardiomyopathy is in this category as well, and it is I-25.5. Now, ischemic cardiomyopathy is a form of CAD, but it does not risk adjust for parts A and B. However, it does for your Medicare Part B. It does not mean that a patient has heart failure, but it obviously is a cause of heart failure. So if the patient has ischemic cardiomyopathy and any stage of heart failure, you have to document both. You have to document the heart failure, the ischemic cardiomyopathy, and the stage and type, if known, of the heart failure. And I'm not sure, what really is meant sometimes when I see this documentation, but a lot of times I see ischemic cardiomyopathy documented, and if it's already coded when it comes to me, a lot of times I see it coded in the ICD-9, the 425.4 category, which is actually incorrect. Ischemic cardiomyopathy in ICD-9 would index to 414.8. So if it is indicative of heart failure, it must be documented. Excuse me. Any questions on the CAD documentation? It's pretty self-explanatory and relatively the same as ICD-9, just the combination codes are present. And then when we're going to talk about angina, it's going to be, you also are going to have to state what type of angina, but we're going to go over that now. No questions? Okay. So coding angina pectoris in ICD-10. There are no major changes. However, we are now, it's formatted a little differently. So if you see there, in the I-20 category, you have a code for unstable, which is angina, which includes the intermediate coronary syndrome. You have a code for angina with documented spasm. You have a code for other forms of angina and one for unspecified angina. In comparison to the ICD-9 category, which was 413, you had angina decubitus, you had Prinz-Metal angina, which included variants. This in ICD-9 is what is considered documented spasm in ICD-10. And then you had other and unspecified. So when you say angina, ICD-10 expects you to document which type, stable, unstable, other. Let's try to stay away from unspecified. They're giving you unspecified codes in ICD-10, but they really would like you not to use them. Okay. Not many times are you going to encounter an acute MI in the PACE setting. However, it has happened, so I wanted to include this so that you would understand the new coding. Myocardial infarction is I-21. So for an old MI, it's the same as ICD-9. It's just old MI. It's I-25.2. The difference between 9 and 10 in terms of acute myocardial infarction is this. They have shortened the time frame for coding. So in ICD-9, you could code an acute MI from onset to 8 weeks. Now in ICD-10, you can only code the acute MI from onset to 4 weeks. There is also more specificity in ICD-10 in terms of naming the artery involved and the laterality, not just the wall. So in ICD-10, it would be left anterior descending coronary artery. You also have your choice of STEMI or non-STEMI. It does allow for an unspecified site. So to further talk about myocardial infarction, which I know it's not on here, but I just want to expand on this a little bit further. Basically, the impact here is after 4 weeks, you have to use an aftercare code, after 4 weeks of the initial. Should the participant have an acute MI and then within that 4 weeks have another one, you can code that. It just goes into category I-22 for subsequent and recurrent. No longer do the codes contain initial and subsequent in one category. They're now I-21 for acute, I-22 for subsequent. Okay. Any questions on either angina or myocardial infarction? Okay, we're going to talk about arrhythmia. I'm very happy to report that there is now a code for paroxysmal atrial fibrillation. It didn't really change anything because in ICD-9, you could code paroxysmal AFib as long as they were being treated with 427.31. But apparently this has been quite typical, so they have now included. So what's new for AFib and A-flutter and 10 is there are now specific codes. It's the I-48 category, I-48.0 to I-48.2, paroxysmal, persistent, chronic, and unspecified for atrial fibrillation. And for A-flutter, which I can honestly tell you I don't see too often, but it is I-48.3 or I-48.4. And this includes typical, which is type 1, and or atypical, which is type 2, atrial flutter. And again, you also have your unspecified atrial flutter. So I want to talk to you a little bit about the new requirements in ICD-10 for the tobacco use and exposure. I know we've mentioned this a few times, and then in the next webinar I'm going to mention it some more because it's the respiratory conditions. So in ICD-10, as we have said, it includes additional codes to identify tobacco use or exposure, which are the D codes. You have the choice of history or current use, and then it further expands to dependence, environmental or occupational exposure. Certain diseases and conditions now include, as I said, the instructions for the additional code, and here they are. Exposure to environmental tobacco smoke, if you feel that the condition was caused by such. History, occupational, again, the same thing. If you feel that the condition was, it doesn't mean you don't have to document this, but if you feel that it is caused by it has caused the condition, such as for an artery disease or COPD or what have you, then you can put those codes in there. Tobacco dependence, there are 20 codes in that category, and I'm going to show you what they are. And also tobacco use, which is the 72.0. If you notice, the Z category is basically kind of taken over the V category in ICD-9. So let's talk about nicotine dependence. You have nicotine, this is the F17 category. You have nicotine dependence unspecified, F17.20, nicotine dependence cigarettes, nicotine dependence chewing tobacco, and nicotine dependence other tobacco products. So the reason why I'm telling you this is because when you document nicotine dependence, it's going to require you to document every little last detail about the nicotine dependence. So let's look at some further breakdown of the F17 category. It is further specified, each and every one of those categories is further specified as uncomplicated. So let me go back. You have nicotine-dependent cigarettes, uncomplicated, in remission, with withdrawal, with other nicotine-induced disorders or with unspecified nicotine-induced disorders. The comparison to ICD-9, you had two TEDs. You had tobacco use or dependence, which is 305.1, and you had a history of it, which was V15.82. So we have significantly increased the codes in ICD-10 just for tobacco use. Okay. Any questions on that? Okay, moving on. Here's my documentation example. 72-year-old female seen 1 week earlier in the emergency department with a history of sudden onset of right-sided chest pain and shortness of breath, which had started 3 hours prior to her arrival. The pain was made worse with deep inspiration. Exam at that time showed vital signs of pulse 110 and regular, BP 140 over 102, temps 98.6, respirers were 26, stats were 83% on room air. Physical exam showed swollen right lower extremity, which was painful and warm to the touch. A pleural friction rub was heard over the right lower chest posteriorly. Doppler ultrasound of the right lower extremity showed deep vein thrombosis. Pulmonary CT angiography showed total occlusion of the right lower artery, right lower leg artery, as well as signs of right lower lobe, artery, as well as signs of chronic pulmonary artery hypertension. Patient diagnosed with hypertensive heart disease with mild chronic left ventricular diastolic failure and mild pulmonary artery hypertension 2 years previously has been managed on ARB therapy without complication. Review of systems, physical exam, and laboratory tests. We've talked about the vitals, chest, dullness to percussion over right lower lobe posteriorly with decreased breath sounds in the same area. Right lower calf mildly swollen but not warm or tender. Chest X-ray was moderate, showed a moderate-sized pleural effusion on the right. Lab, the INR was 3.2 on Coumadin at 10 milligrams a day, preferred range 2.0 to 3.0. Assessment and plan. Acute right lower lobe pulmonary embolism, continued Coumadin but reduced dose to 5 milligrams a day. This indexes to I-26.99 and it maps to HCC 107. Acute right-sided pleural effusion, presumed secondary to PE. Following 2 weeks with repeat chest X-ray, it is coded J91.8, irregardless of the fact that it says presumed secondary to PE, because all we're coding with J91.8 is the pleural effusion. Acute DVT of the right leg, continued Coumadin, I-82.401, HCC 108. The thing to note here is that the 107 is going to hierarchy out the 108. Acute respiratory failure with mild hypoxemia, arranged home oxygen at 2 liters per minute by nasal cannula, J96.01, which is HCC 84. Hypertensive heart disease with chronic mild left ventricular diastolic failure, continue ARB therapy, I-111.0, I-50.31, and that is HCC 85, as well as chronic mild pulmonary artery hypertension, which is I-27.2, and remember that pulmonary hypertension also maps to HCC 85. That is all I have for today's webinar in regards to CHF, hypertension, CAD, and angina. Our next webinar will be on COPD, asthma, chronic respiratory failure, and I'm also going to include malnutrition and pressure ulcers in general. That will be on Thursday, August 27th at 2 p.m. Central Time, 3 p.m. Eastern Time. You are going to, again, receive a survey via email. And if you have any additional questions that we may not get to today, you can submit those questions to Dr. Richard Champ, rchamp at cpsdn.com, or myself, Angie Ladd, at alad@cpsdn.com. So at this time, if anyone has any questions regarding the content we covered today, you may press *6, and we will start the question and answer session. If you do not, I thank you all very much for attending today's webinar and look forward to educating you on the next one. Hello?
Yes, hello. Hi, my name is Rico Costa from Community Life in Pittsburgh.
Uh-huh.
And the one really confusing aspect to this, not necessarily your presentation, but the ICD-10 itself, I've noticed it does this in a couple of areas, but the one in particular that we were addressing today is in ICD-9, of course, we had the 414.00 and the 414.01. So you could, if somebody had a bypass graft, let's say, you could use the 414.00, and then the doctor wouldn't have to specify where the disease is actually at. Or if they have not had a bypass graft or any other type of, repair of an artery, then you would use the 414.00 for native coronary artery.
Right.
I'm assuming that's a correct way of looking at it, right?
It is. And usually, I can honestly tell you that the two most common codes for me in ICD-9 are 414.00 or 414.01. And like you said, if they don't have any documentation that they've had a bypass graft or a bypass or stent or anything, then yes, you are instructed to use of the native coronary artery. And this is, most of the time, I think the reason why it just said, I'll see documentation that says CAD, history of cabbage or history of stent. And at that time, I always code it unspecified because a lot of times the provider may not know where was the CAD, or where is it? Is it in the bypass graft or what have you? So in ICD-10, it's going to be the same thing. You're still going to have an unspecified code if the documentation does not state.
Okay, so that is good, but what is the unspecified code? Because the only codes that we've encountered have been of the native coronary artery or of one bypass artery or vein or another, many different types. So where is there an unspecified code for that?
See, I'm looking in here for you to see and tell you exactly what code it will be. You have a code for atherosclerosis of other coronary vessels without angina pectoris. So you know what, you're right. You're going to either have to, where you're unspecified is atherosclerosis of other bypass graft, other coronary vessel, or native artery. So they are at this time going to be forced to say either native artery or bypass graft, it looks like, now that I'm looking at it.
Okay, here's the other thing, and I mean to monopolize this, but this also comes up with a couple other different categories which are extremely frustrating. One of them is the major depression, which I know I'm not going to get into that right now. But but for instance, I-25.10 specifically says atherosclerotic heart disease of native coronary artery without angina pectoris. Okay, then underneath it, it says atherosclerotic heart disease not otherwise specified, which would lead you to believe that if it's not specified, that's what you would use, except that the description comes up of native coronary artery. You know what I mean? It's like, I'm not sure. There are a couple other instances of this, and I'm hoping like in future editions they might address some of these things. But it seems to me that they put the unspecified code underneath a specific code. You know what I mean? Instead, okay, just use that one instead of creating another code. I wonder. I mean, is that am I looking at that correctly or?
Yeah, you're right. You are looking at that correctly. So what they're doing in ICD-10 is forcing you to state, is it of the native artery or is it of the bypass graft? So I mean, really the suggestion I have is that, the provider is going to need to, if they're the one ordering the test, then just pretty much state what's on the results of it, of like an echo or what have you, and also or get good medical records, because it's going to come back with a query to say where is the CAD.
Right, and and certainly, that's always good advice. Is to make the documentation as specific as possible, whatever it is. But as you know, in the real world, which I don't have to tell you, as you know about, and especially geriatric medicine, with people who may not even remember their own histories, and the coronary artery disease may be long-standing to where it's not even possible. I mean, sometimes they'll have pacemakers and they won't even know why they have a pacemaker. So, so that's, I think that again, hopefully that will be something that will be addressed. And just in general, without dwelling on this, do you think that those types of things may be addressed in upcoming updates as they have been in ICD-10 over the years?
Yes, and that's the problem, because there's a coding clinic for ICD-10, but the coding clinic is comprised of those coders who have asked multiple questions on how to code things, which is where they have gotten this. Unfortunately, it doesn't exist in ICD-10 because nobody's done it yet. I do look for it to happen, and I have actually submitted several questions myself. So I know that they're going to they're going to cut us some slack for the first year, just because of the simple fact that we just don't know, But, as far as questions that I have answered, or I have had, tried to find the answer to, they're just sometimes not a clear answer. And ICD-10 is supposed to be more clear, but it's not, as with all coding, it's not black and white, and I'm still finding that it's not black and white. So I do look for it to help and to be remedied in the future, but I just think it's going to take a little bit of time for it to be so. So, my advice to the coders is just to, query when necessary and code to the, code as best you can for the information that you're given.
As specifically as possible, and then ask questions to the coding clinic, then obviously too.
Right.
So that the more input, the better. And
right.
Okay, well, I thank you very much for taking the time. I really appreciate that thoroughness of your answers. Thank you.
Sure, not a problem. Thank you.
Hello?
Hello?
Hi, my name is Donna, and I'm from Mercy Life in Bluebell, Pennsylvania.
Uh-huh.
And I just have a question. Going back on the webinar we just did, it's actually on page 13, and it has to do with coding arrhythmias.
Okay.
And this is just a quick question. Could you clarify the difference between persistent and chronic for AFib specific codes?
Let me see if I can find that for you. Nope, that's not it. Here we go. Okay, so we're talking about the I-48 category. And you're asking the difference between the persistent and chronic atrial fibrillation. So the way I understand it is that persistent is that you have AFib that is persisting almost that it is, you're trying to treat it, it's not working. And then you have chronic AFib, which is more of a permanent AFib, that you cannot cardiovert them out, they're an AFib, and that's the way it is, and the only thing you are really controlling at this point is the rate. Does that make a little bit of sense?
Do you mind saying that one more time? It did, but
the main difference here, mainly what you want to look at is the chronic. The chronic AFib are those patients who are chronically an AFib. So, so I don't know if you're a nurse or a provider or how
I'm
or
a nurse.
what, but okay. So when if somebody comes in AFib with RVR and they try to cardiovert them, and sometimes it works and sometimes it doesn't. Okay, well, if they have chronic atrial fibrillation, they're just in atrial fibrillation. They're not, they're not back and forth between normal sinus and AFib. They're just, that's what their heart rhythm is. It's chronic AFib.
Okay.
So obviously the difference between paroxysmal and persistent is that paroxysmal, that every once in a while they go into AFib, it's not all the time, and then
but then they come back out.
Yeah, paroxysmal, they can come back out. You can still post for paroxysmal if you're saying, okay, well, we're going to put them on, a rate control. You want to keep them on that so that if they would happen to go, back into atrial fibrillation, they're not going to go into RVR or anything like that. That is my understanding of it. I don't really see, again, unfortunately, with the last question, as he was asking, there just is no coding clinic and no examples to specify or to differentiate between the two. So that is my understanding of.
No, that was helpful.
Good. Okay.
Thank you so much.
You're welcome.
Okay.
Any other questions for today? Okay, well, I do not think that we have any further questions. However, if anyone should have a question after this webinar, again, please feel free to email myself or Dr. Shamp, and we will answer your questions as best we can. Again, I want to thank everyone for attending today's webinar, and stay tuned for webinar number 4 regarding the respiratory system. Thank you all very much, and have a great afternoon. Bye-bye.